Welcome to today's PCR webinars. I'm happy to be joined by our colleagues Mohammed Abdel Wahab from Leipzig, Germany, Hemal Gada from Pennsylvania, Harrisburg, and myself, Nicolo Piazza from Montreal, Canada. And today's PCR webinar is going to concentrate on how we can reduce permanent pacemaker rates using the Cusp overlap technique during transcatheter aortic valve replacement. So why don't we start off with looking at the objectives of today's session. And so we're going to review three main objectives. The first is to review the factors that can be associated with permanent pacemaker implantation. The second will be to learn how pre-TAVI imaging can help us understand and reduce the risk of new permanent pacemaker implantation. And the third is to understand how the cusp overlap technique during the implantation procedure can impact permanent pacemaker rates. So welcome, gentlemen. Why don't we, Mohammed, start off with the case and then we'll have a bit of discussion right afterwards.
Yes, I think we can just move to the first part of the case, which was recorded a few months ago in Leipzig. So unfortunately, we couldn't do it live as previously planned because of the current pandemic situation. But let's have a look at the first part of the case and then go back and discuss.
Welcome from the Heart Center Leipzig in Germany. My name is Mohammed Abdel Wahab. I'm an interventional cardiologist, and we're happy to present you a recorded live case today from our hybrid operating room. On my right-hand side, Philip Kifa, who is a cardiac surgeon, and he's going to do the procedure with me. And also in the room, we have Vladimir from the anesthesia, Petra, Norbert, and Mike. And our patient today is a female patient. She's 77 years old. You can see here that she's a little bit overweight with a body mass index of around 30. She has some comorbidities. So she's hypertensive. She has a known diabetes mellitus. She's hyperlipidemic, and we talked about the overweight. And she also has some chronic renal insufficiency, which is probably secondary to her cardiovascular comorbidities. Her prior clinical history is relevant concerning a left-sided mastectomy followed by radiotherapy for breast cancer, which was almost 1 year ago. The patient luckily recovered very well from this operation, and she now presented to us with progressive shortness of breath, and she had one attack of syncope. Her laboratory investigations were overall unremarkable, so the hemoglobin level is normal. I remind you that this is in millimole per liter. Her creatinine a little bit elevated. We talked about the renal function. She has almost normal NT-proBNP, only slightly elevated, and a slightly elevated hemoglobin A1C. Otherwise, as previously mentioned, her laboratory values were unremarkable. This is her ECG, and you can see here that she has normal sinus rhythm, and she has narrow QRS complex with no bundle branch block. And on echocardiography, as you might expect, she has a clear high gradient aortic stenosis with a mean gradient of 48 millimeters of mercury, an effective orifice area of 0.9, no relative AR, and a normal LV function. The patient was diagnosed actually at an external hospital, and they did a coronary angiogram, and you can see here that she has some coronary artery disease, but no significant lesions. And this is her multi-slice CT. You can see here that she has rather favorable femoral access with the good size of the femoral and iliac vessels on both sides. And when we look at the valve itself, you can see here that the valve is more or less moderately calcified, a little bit asymmetric calcification on the non-coronary cusp. And she has overall a small anatomy. So we can see here the annular dimensions, the area of 335, a perimeter of 66.5. So the area and perimeter derived annular diameter is between 21 and 21.6. She had good distance to the coronary artery. So overall, a favorable anatomy for TAVR, despite the fact that this is considered a small anatomy. Interestingly, and this is something we still don't do routinely, but we do it in selective cases, and we did it for this case as well. You can see here the measurement of the membranous septum. So she has a very short membranous septum, just around 1 millimeter in length. The width is 9 millimeters, so a very short membranous septum, and we know, and we will discuss this, of course, carries high risk of permanent pacemaking afterwards. Risk scores, the traditional risk scores, STS and Euroscore 2, put this patient into the category of low risk. The patient has no frailty characteristics, so she is still an active patient. She's 77, has some comorbidities, but she's active, doing her household with no restrictions except for the shortness of breath she has. And to summarize, and maybe afterwards we go to the panel discussion, this is a 77-year-old low-risk active lady. She has a body mass index of 30. She has severe symptomatic AS, no significant coronary artery disease. And when it comes to her anatomical characteristics, she has a small aortic annulus. She has no adverse root features, but she has an extremely short membranous septum. And I think this is where we may stop for a while and discuss potential options, and then return to the case.
Yeah, so this is the case we did a few months ago, and I think there could be a couple of issues to discuss up front. I mean, the classical question would be, would this be a straightforward TAVR candidate in your practice, Nico and Hemal, or would you discuss also like the surgical option in her case? What would be your thoughts about this? Nico?
Go ahead, Hemal. I'll come after.
Yeah, sure. So no, I mean, I think that this is a very appropriate candidate for transcatheter aortic valve replacement. I think that we would probably define her as intermediate surgical risk based on her age and comorbidities, in addition to her renal function. And so all those things would kind of toss her into the realm of being considered clinically for transcatheter aortic valve replacement. I know we're going to get to valve size and choice, but just to start off that discussion, if we're picking a surgical aortic valve replacement size, I would be curious to see what the surgeons would do. Are we going to get a 23 millimeter surgical valve in there? And would that involve a root enlargement? These are questions that I definitely would be asking, because I'm thinking about the size that I would be able to offer on the transcatheter heart valve size.
Yeah, I agree with you, Hemal. There's two things here that sort of point towards a transcatheter aortic valve replacement. One is the renal dysfunction. It's moderate. A GFR of 38 is not too great. And second is the risk of patient prosthesis mismatch, which we know these two complications, acute kidney injury and PPM, are much reduced with transcatheter aortic valves, especially when selecting a self-expanding valve.
Yeah. So I think this is exactly what we thought of this case. But one thing we were discussing more frequently in the past month, after we understood the impact of this of the length of the membranous septum on conduction disturbances after TAVR, I'm not sure whether we have data about its impact on surgical valve replacement as well. So I personally, I don't know if we have any published literature on that. But is this something that is being integrated in your discussions in your heart team? If you find a very short septum, or if you have a high risk of conduction disturbances after TAVR, that this would something that favor surgery maybe in a few cases? Hemal?
Yeah, that's a great question, Mohammed. I think that, in all honesty, we've become quite adept at landing these valves shallow when the circumstances, would permit that or make that something that would be favorable. I think the great thing about the self-expanding prosthesis is that doesn't foreshorten, and you can be pretty precise with regards to where you land it. And Nico's going to go over the fluoroscopic reasons why this anatomy makes sense in the lab and how we're going to land and tailor valves accordingly. But I think, if anything, it makes us favor deployment of a self-expanding prosthesis in these particular anatomies.
Mohammed, similar to you, we don't do this measurement of the membranous septum routinely, although we do look at it when we start thinking about whether or not we can afford to go deep. Depending on the anatomy, sometimes you do look for areas where you'd like to seal. In some cases, you like to seal higher up in the anatomy, and in others, you'd like to seal lower down. And so, I think it's a good way to maybe provide a prognosis about permanent pacemaker. But we need to realize that this concept, I think, is still in its childhood years, and we're starting to learn more and more how to use it.
Yeah, Mohammed, I've got a quick question for you. So, as far as the measurement of the membranous septum length is concerned, we're all familiar with that paper that came out of NYU with the membranous septum length and that portending worse outcomes with regards to conduction disturbances, especially if membranous septum length was less than 2 millimeters. But I would argue that the membranous septum length is not a uniform structure, and that whole width of membranous septum that you defined, it's not like you had a 1 millimeter length on the membranous septum, that entirety of the width. So I'm wondering how you kind of integrate both pieces of information there.
Yeah, it's a good question, but I'm really not sure whether we know how to integrate the width of the septum in our length measurements yet. So we're starting to get a feeling for that. We've realized that when we tried to retrospectively assess this, that we have a large number of patients where we couldn't assess it retrospectively simply because imaging acquisition didn't allow. So this is the first thing we understood, that if you want to do this on a routine base, then you probably need to modify your protocol a little bit, because you need the right ventricle, obviously, to be opacified as well. So I'm not sure yet how to integrate actually this width into our length measurement. So we try to measure it according to the publication you mentioned, but we're not sure yet how to integrate the width of the septum into this.
Okay, Mohammed. So shall we maybe move forward?
Yes, so obviously we decided in her case for TAVI, and because of the small anatomy, and this is what we usually favor in small anatomy, we favor the use of self-expanding devices if the anatomy allows. And in her particular case, we were considering the short membranous septum in our implantation technique in order to try our best to reduce the occurrence of AV block. So let's move to the second part, and then I'm sure we will build upon this discussion in a few minutes.
What we did until now, and we can show you on the images we have taken. So the first thing after obtaining access, this is the placement of the Sentinel device. So nothing outside of the routine practice. This is the 3-cusp coplanar view, which is in her case an LAO with a little bit of caudal, I think. And then we have also the cusp overlap view, what I personally like to call the non-coronary side view. But I mean, it's the same. You're looking here at the non-coronary cusp from the side view, and the right and the left cusp are overlapping. And this view we are going to use in order to optimize implantation depth. We're going to switch between views, but also for commissural alignment, which is something we want to demonstrate. We already crossed the valve. Valve crossing was more or less uneventful, and now we will proceed with placing a safari wire in the left ventricle. And Philip, would you like to comment on?
So let's pause here for a while, and I think it's important, Nico and Hemal, to explain maybe for those implanters that are not very much familiar with this terminology, cusp, overlap, non-coronary side view. I mean, we're talking more or less different terminologies, but at the end of the day, we're describing the same thing. So I'm sure, Nico, you want to demonstrate this in a few slides to make people familiar with what we're talking about.
Sure. Okay, so, why don't we take the next 10 minutes or so to really understand exactly what is hiding behind these three cusp coplanar views, or the non-coronary cusp view, or the cusp overlap view, because there is actually a heart behind the fluoroscopic image, of course, that we don't see. And we're going to try to understand this anatomy with respect to chamber views. So I think we're all familiar with the echocardiography chamber view, where we have the short axis or one chamber view. We get the two chamber or the bicommissural view. We can have the three chamber view, also known as the LVOT outflow view, or we have the four chamber view. Now, as this video runs, what you'll see is that we start off in an ariocaudal view with a three chamber view. We move towards an elaiocaudal view. We get a short axis view of the heart. As we drive in elaeocranial, we get a four chamber view. And we can then move the gantry towards a areocranial, and we'll get the two chamber view or the bicommissural view. And in fact, this is the view that we do our everyday LV grams in the cath lab. So the formula on the fluoroscopic grid is the following: the one chamber or short axis view in elaiocaudal, the three chamber view in ariocaudal, the two chamber view in a shallow areocranial, and a four chamber view in elaeocranial. Now, what we're seeing here is the aortic annulus optimal projection curve, or S-curve, and we are riding along this S-curve. What we want to notice on this moving image is that as we are moving along the S-curve and having the aortic annulus in plane, we are actually appreciating chamber views along this S-curve. Okay, so you'll see that we're going to start now with a three chamber view in ariocaudal. Here we go, three chamber view in ariocaudal, aortic annulus in plane. And if we continue the video, we will see that the three chamber view then progresses. Okay, so we have the three chamber view with the aortic annulus in plane. We then move towards a two chamber or almost a quasi short axis view of the ventricle with the aortic annulus in plane in AP. And as we're moving in elaeocranial, we get the four chamber view and the three chamber mirror view in extreme elaeocranial. The aortic annulus has an S-curve that looks something like this in almost every patient. It drives in the ariocaudal to AP to elaeocranial, whether or not patients have aortic or mitral valve pathology. So if we go back to this fluoroscopic grid with the chamber views, we can superimpose the aortic annulus S-curve. Okay, and this is a nice summary slide of the aortic annulus S-curve and the chamber views that you can get on this annulus S-curve. So you appreciate the three chamber view, LVOT view in ariocaudal, and as you drive across the annulus S-curve in elaeocranial, you get the four chamber view. Now, this is the aortic valve en face. The non-coronary cusp is highlighted in yellow, the right coronary cusp in red, and the left coronary cusp in green. And depending on how you are visualizing this annulus in plane, you will appreciate the different cusps, whether they are separated or overlap. So let's take this first eye, and you can see that in its field of view, it will isolate the non-coronary cusp, and it will overlap the right and left. As you move along the S-curve from 1 to 2, you now appreciate the non-coronary, the right and the left, all separated. As you continue to rotate along the annulus S-curve, you get to a point where you overlap the right and the non, and you isolate the left cusp. And finally, you can also go in an extreme eleocranial where you'll have the non-left and right cusps isolated. So this is basically a summary of what we just spoke about. In the three-chamber view on the far left, in the ariocaudal view, you have the non-coronary cusp that's isolated. In the four-chamber view, in eleocranial, you have the left coronary cusp isolated. And if you go really extreme LAO and cranial, you'll have the right coronary cusp isolated. And in fact, those areas where you isolate the left coronary and the right coronary cusp are in fact the best views to appreciate the left main coronary artery and right coronary artery. Okay, so if you go back to the aortic annulus S-curve, not only can we understand chamber views on this S-curve, okay, but we can bridge the S-curves, chamber views, and now the anatomy of the coronary cusps. And you can see that the big dots here have the isolated non-coronary in yellow, in ariocaudal, the isolation of the left coronary cusp in a shallow eleocranial, and you can isolate the right coronary cusp in an extreme LAO and cranial. Now, between these views, you'll have the three-cusp coplanar view. So in fact, as you're driving along the annulus S-curve, you're going from isolation of a coronary cusp, three-cusp view, isolation of a coronary cusp, three-cusp view, and isolation of a coronary cusp, etc. So when we talk about the actual cusp overlap view, what we like to do is we take our multiplanar reconstruction lines and we take one of them and we make them overlap the left and right coronary cusp. The orthogonal multiplanar reconstruction line should cut across the non-coronary cusp. In this way, you'll have the overlap of the left and the right and isolation of the non. And so the two most common views to implant a transcatheter aortic valve is in a three-chamber view where you have isolation of the non-coronary cusp, or what we call the cusp overlap. And that cusp overlap is the overlap of the right and the left. Or we have the two-chamber view in AP view almost, where you have the three-cusp coplanar view, where you have the right and the left cusp that are separated. Now let's just talk in the last two slides about what we appreciate in these two traditional or common TAVI implantation views. This is the two-chamber view or the three-cusp view. You can notice on the 3D image that the left ventricular outflow tract is foreshortened And in fact, the mitral valve is sitting behind. The LVOT is projecting backwards into the screen. Okay. Also, in this two-chamber view or three-cusp view, we typically get closer to the major axis of the aortic valve. On the other hand, in the three-chamber view or the cusp overlap view, okay, you can appreciate that we brought forward the LVOT. We have elongated the left ventricular outflow tract and aortic root. And because our delivery catheters follow the anatomy, and because our anatomy is not foreshortened now from aortic root to LVOT, it will also elongate our delivery catheters. The other thing, in addition to trying to eliminate parallax and foreshortening in the three-chamber view, is the fact that we get the minor axis in the three-chamber view of the aortic valve. And so we can appreciate earlier contact of the prosthesis with the anatomy in this view. Now, although we don't have enough time to discuss this, the cusp overlap technique is very closely related to the double S curve. The double S curve was a technique that we developed about, I would say, 8 to 9 years ago, where we get two coplanar views of the delivery catheter. We use the pre-procedural aortic annulus S curve. We put together the S curve of the delivery catheter, the S curve of the aortic annulus, and somewhere where these S curves intersect, it's going to give us the view where both the anatomy, the aortic annulus is in plane, and your delivery catheter is coplanar to the X-rays. And in about 90 to 95% of the time, this always happened in an areocaudal view. I have to admit, Hemal, that in the first 6-7 years of doing the double S, what we didn't realize is, in fact, we were using the cusp overlap technique. And so we went retrospectively and compared the double S and the cusp overlap technique in a manuscript that's recently published in JACC Interventions. And we found that the double S and the cusp overlap technique agree in over 85 to 90% of cases. And so what you tend to appreciate when you do the cusp overlap technique is, as you advance the delivery catheter across the annulus, in the vast, vast majority of patients, that delivery catheter should come into plane. And in about 1 out of 10 cases, it might be slightly off. And what we do is we try to understand the aortic annulus S curve, and usually you have to go just slightly more caudal in order to take off the parallax from the delivery catheter.
These are great points, Nico. I mean, I think that the work that you've done understanding the anatomy of the annulus and the LVOT on fluoroscopy has just been monumental in helping us understand how to tailor these deployments relative to the conduction system that I'm sure we're going to go over after Mohammed's next segment. What I will say about this is that I think wire choice does tend to matter. Right now, we have a 2-spine system with the self-expanding prosthesis. And so depending on the lie of the aorta and how it relates to the left ventricle, the 2 spines may promote some rigidity that you may need a stiffer wire in order to navigate that minor axis and stick to the posterior aspect of the annulus and the non-right commissure more effectively. So I think that's something that we'll be able to talk about. Obviously, our wire choice, our preference is use of the double curve Lunderquist for this specific reason. But I'm sure that we'll have a spirited discussion about wires to come. But the knowledge of the anatomy is absolutely critical in tailoring this technique.
Yes, I totally agree. And I think the beauty of understanding this, as you've shown, Nico, is that you understand the chamber anatomy, but you also understand the anatomy of the aortic valve and of the different cusps. And this, it started with implications for valve positioning and avoiding misplacement and reducing pacemaker rate, but it's moving forward to understanding how to align the valve. And even when we do complex procedures such as basilica or something, we need to understand this in order to identify the different leaflets and how we place our catheters and so on. So I mean, you buy one and you get two for free. You understand chamber anatomy, and then you understand alignment, basilica, and so on. Okay, so if you agree, we move back to the case.
Okay. Our discussion concerning predilatation.
Yeah, well, in this case, we decided not to do a predilatation because the calcification, as you can see here in the fluoroscopy, is not that excessive. So we're going for a straight implantation of the core valve and maybe end up with a post-dilatation. But in this case, we're not doing the predilatation. Maybe just to finalize the discussion, we of course have discussed this patient in the heart team in our daily matter, just to make sure whether she's really a transcatheter candidate or, of course, a surgical candidate. And as you have seen in the presentation before, there are a lot of things that have to be addressed for this patient, especially the breast cancer radiation of the thorax, and of course the creatinine level. And of course, the 77 years old, and I think we clearly decided for a transcatheter procedure.
Small anatomy could be something that can favor TAVI, but there are also a lot of surgical options. We can discuss this, of course, as well. The short membranous septum could be, in my opinion, an argument for surgery, because I'm not sure whether we have total control in the case of a very short septum, as in her case. So we will do our best, but at the end of the day, we also need to anchor the device, so we'll not be able, and we're not aiming at implanting the device at 0.
Yes.
I think not even at 1, so we'll try to implant maybe at 2 or 3 millimeters. It's very important to consider implantation depth, but also in the context of the small anatomy, coronary axis, and anchoring. Yeah?
Absolutely.
So now, just to have a look here at the flush port, please. If you can see it, yeah, with the head camera. We have the flush port now at 3 o'clock, and we know that this flush port marks one of the C-tabs, which overlies the commissures. So if you see this on a graph, you will easily understand this. So these are the markers we have. If you go at 3 o'clock, then probably, as you can see here on fluoroscopy, in a normal anatomy, you will see here that the hat marker, if we go a little bit in LAO, open up the curve a little bit, the hat marker will be probably at the outer curve. You cannot see it here quite nicely, but you will see it when we cross the arch. So in this case, the hat marker is, as you can see here now, when we go at 12 o'clock, it's on the outer curve. We'll remain, actually, despite this fact here, in this case at 3 o'clock, cross the arch and see now where we will land. So we can see here that we are coming actually very nicely through the outer curve. So despite that the hat marker was not on the outer curve in the descending aorta, just by maintaining the 3 o'clock position, you usually obtain a very nice position in the ascending aorta, and this is actually what matters. Exactly. Okay. What we do here in this case, we then switch to the cusp overlap view, to the non-coronary side view. And you can see here, this is very nicely demonstrated here. In this case, I'll take a picture of that. And you can see here that in this view, the hat marker is located center front. So it's exactly in the middle. And this is actually a slight adaptation to the technique described by Tang et al., a little bit adapted to the patient anatomy. So if you are in the non-coronary cusp or non-coronary side view, cusp overlap view, if you are center front, probably you have a very even higher chance of commissure alignment than if you're not. Okay, so let's cross the valve here in this view. Okay. We have rather good coaxiality, so Philip is keeping the wire, helping me a little bit. Maybe a little bit of push on the wire, Philip, just to try and be a little bit more coaxial. Okay. And we'll start maybe implantation or unsheathing of the valve here at this position. We will pace Vladimir at 140 when I give you the signal. Okay. Yes. So we'll start here. No, I'll tell you. We are starting unsheathing now, but we'll still wait a little bit. Okay. So it's important here that what we usually do is that the first operator has both the delivery catheter and the wire, and the second operator is unsheathing. So I'm trying to come a little bit higher up, and then we'll open a little bit more. Okay, let's do an image here. We stop for a moment. Angie bitte, Schuss. You can see here that the pigtail is not perfectly in place, so we still need to optimize this. So we have to get the pigtail down. We'll go a little bit inside. This helps us also to maintain or to have better alignment. Okay, and then we continue. Okay, we'll stop here and take a picture again. Schuss.
Oh, that's
Okay,
good.
yeah, I think it's fine. We are maybe at 2 millimeters. So let's start pacing here, please. 140. Okay, let's film this and we'll do it very slowly. Okay, so we'll stop here. Stop
here.
pacing, please. So very controlled deployment, and let's see if we are fine or if we are a little bit too high or too low. Let's do an angiogram here.
That looks good.
So in this view, it looks good.
Yeah.
Of course, it's on the non-coronary side. We cannot really go much higher. No?
Yeah.
If you look at the ECG now, probably she's now having like some sort of an intermittent left bundle branch block, but she's still in sinus rhythm. Yeah, so the bundle branch block has now gone.
Yeah.
So now she's still in sinus rhythm. But it's extremely important here that we go back to our other view, just check again the depth or the height on the left coronary side as well. Because we have a little bit of a parallax here. And you can see here, still we have parallax here on the left side, so let's try to adjust this a little bit. And maybe zoom a little bit on the valve. Yeah, a little bit more zoom.
No more zoom?
Yeah, so we're zooming a little bit. Try to get rid of this parallax in order to be able to adjust height. What do you think of that, Philip?
Well, from here it looks really good, to be honest with you. It's just like maximum of 2 to 3 millimeters below the annulus, and I think the position is really good.
Let's do a picture here again. Angie und Schuss. Yeah. So still a bit of a parallax here. I mean, it's important, and you see that we are taking our time. It's important if you're going to implant high, that you make sure that you're not too high, correct? Because, I mean, the advantages and the disadvantages of a high position, I think, are clear to everyone. And we want to make sure that we are at the correct depth. So let's take a picture here without an angiogram. Yeah, it looks better here. What do you think, Philip?
I think it's really good because we have no regurgitation seen in the root shot. We have a nice height, and we also have to keep in mind that we have the membranous septum. So going deeper may cause the problem of AV blockage.
Exactly. And the nice thing about her anatomy that we are also like aligned on both sides, so we're not deeper on the left or on the non side. Usually you get deeper on the left side if you have a very vertical anatomy. So it's not the case. So I think we're fine.
Yeah. So let's discuss a little bit here. I mean, we still could reposition if you wish. Let's have your thoughts about that. And I would be interested in knowing, I mean, the technique or the cusp overlap technique is still, I think, evolving. So there are still some nuances, and I would be interested to know, Hemal and Nico, the first thing I would like to ask you, maybe Hemal, is where do you start unsheathing the valve? I mean, do you start unsheathing it after crossing above the annulus, below the annulus. And the second thing is, I mean, we switched a lot between the cusp overlap view and the LAO caudal view, and try to get rid of the parallax. Do you do this as well, or do you think you just stick to the cusp overlap view and that's it?
I think that there are a boatload of things that you've just opened up, and I think that I've got some slides actually to cover most of that. So as far as where we start with the deployment, and then our tips and tricks of how to navigate better to a parallax-free version of an LAO view. So whatever you'd like, if you'd like me to kind of talk through that now, I can.
Yeah, I think if Nico agrees, maybe we this should be a good moment to have a look at these points you just mentioned.
Great, thanks. Yeah, let's go ahead and advance to the slides then. So, Nico put together a very nice overview of echo anatomy, anatomic anatomy, and how we relate that to fluoroscopy. And to Mohammed's point, we're always looking for a bunch of different benefits out of the things that we do. Well, one of the major benefits of the cusp overlap view is that it actually accentuates the conduction system as it would exist below the compact AV node. And so the AV node really emanates on the right atrial ventricular side of the interventricular septum. And then we see the infranodal fibers, the His-Purkinje system, housed in the membranous septum to a variable degree of length, below which they become superficial in the muscular septum. This all happens below the non-right commissure. And so really, if we're going to pick a view that would really accentuate or elaborate the conduction system, it would be a view that would overlap the left and right coronary cusps, leaving the non-isolated. And that's precisely what the cusp overlap view does. There are a lot of advantages to this particular technique. The conduction system is not foreshortened, which is kind of precisely what Nico had talked about, with the elongation of the left ventricular outflow tract and the elongation of the anatomy below the non-right commissure. We actually get distance both between our non-coronary cusp pigtail and the insertion of the non-coronary cusp with the conduction fibers that emanate below the AV node. This is not the case in the three cusp coplanar view and in the LAO view, where the non-coronary cusp tends to be foreshortened and or overlapped with a variety of different cusps. In addition to that, the left ventricular outflow tract is also foreshortened. So you really lose that relationship that you get with such crystal clear clarity in the cusp overlap view. This technique does have other benefits. The radiation exposure to the operator would be much less. Most of the cusp overlap views that we obtain, the right-left cusps overlap, non-independent, are going to be in an areocaudal gantry angle. And that would actually offer you the least amount of radiation exposure. Clearly, the point of this technique is to make it a more efficient and predictable deployment. Mohammed just did a deployment within the span of, 15 minutes. And so, something like that is going to basically obviate to this discussion. But the point is that radiation exposure to the operator is less in the cusp overlap view generally. In addition, and this is something that we'll get back to when we're flipping between views, it is really important to understand exactly what we're looking at in each individual view. So as far as the cusp overlap view is concerned, this is going to illuminate our transcatheter heart valve depth in relation to the insertion of the non-coronary cusp. That's really all we're trying to do there. If we then rotate the gantry LAO to separate out the left and right cusps to understand where we've landed the valve on the left coronary cusp side, keep in mind that usually your visual representation of the non-coronary cusp in that view is a foreshortened representation. And so it's not going to represent the annular plane. In fact, if you rotate the gantry LAO and say caudal to rid yourself of parallax and understand your depth in relation to left coronary cusp, chances are you're going to look multiple millimeters shallower than you actually are on that non-coronary cusp side. And I think this has been the problem with traditional implantation techniques, and the reason why, or one of the reasons why, the core valve and Evolut family of valves has had a high pacemaker rate. A lot of it has to do with the view that was employed in deploying these valves traditionally, which would basically underestimate your depth in relation to the non-coronary cusp, non-right commissure, and conduction system. So, the guide wire, I think, matters. We saw a pre-shaped guide wire in this particular case. I think with a 26 millimeter valve, it's less of an issue. But when you're dealing with a 29 or a 34 millimeter prosthesis, Mohammed made the point during the live case that, he sees a lot of asymmetry in the valve from time to time between the non-coronary cusp and the left coronary cusp depth. And I think you can eradicate all of that by having a stiffer guide wire in place in the left ventricle that will stick to the posterior aspect of the annular plane and the non-right commissure more effectively. Our wire of choice to this point is the double curve Lunderquist wire. It is a safe wire to use if you know how to use it. And now we have actually good safety data coming out of a post-market analysis called Optimize Pro that I'll share with you towards the end of this session. So it is not just a view, there is an implantation technique. So to touch on some of the points that Mohammed was aiming for, we start with the marker band around the level of mid-pigtail and really try to do a top-down deployment to eject the valve down into the annular plane. Now, keep in mind that there's a centimeter of dead space between the nose cone and the base of the valve housed in the delivery catheter. And this will actually help us and facilitate us pinning back that non-coronary leaflet and ejecting the valve downward. What this is going to allow us to do is not need to pull back on the delivery catheter during deployment. And that's something that you really want to avoid, because pulling back on a delivery catheter would imply that you're actually going to then hug the inner curvature, creating more asymmetry to your deployment and a lot more tension stored in the system. As with tab release, you may actually die ventricularly after you release a valve like that. Similarly, with a double curve Lunderquist wire, there should be no need to push or lean on that wire. So really, it's a set it and forget it type of wire. So we really leave that in place as the valve is descending down into the ventricle. We then do controlled pacing. I said I would argue that we usually pace at a higher rate than what Mohammed showed in this particular case. We typically pace at a rate of 180 beats per minute if the patient can tolerate it hemodynamically. Clearly, that's idiosyncratic. If the patient has a poor ejection fraction, bad coronary artery disease, they're hypotensive. We just want to get the pulse pressure down so as the valve stays stable around that third or fourth node. Once it touches or abuts that non-coronary cusp insertion, flaring out to the left and right is much more controlled and horizontal flare versus having any kind of translational movement to it. So we feel that this is important to really get the most efficient and predictable procedure, and the valve remains stable. After we get up to the point of no recapture and we dial down the pacemaker and then shut it off, we're going to do those two checks. One is in the cusp overlap view to understand our depth in relation to the non-coronary cusp, and that's something that we do invariably. We'll then rotate the gantry LAO. Now, I would argue the best way of pivoting around the left coronary cusp insertion, as well as the left coronary cusp attachment of the transcatheter heart valve, is to keep the caudal that you have on during cusp overlap. So say your cusp overlap view is, say, an REO 20, caudal 25. We typically just keep the caudal 25 on, and then we flare out the aortic arch to about an LAO 25. That'll pivot around the left coronary cusp insertion, usually quite nicely. And then with just a little bit of minimal cranial adjustment, you'll be able to take transcatheter heart valve parallax out more rapidly to assess your depth in relation to the left coronary cusp. Keep in mind, again, that in those particular instances where you flared out LAO and you're assessing your depth in relation to the left coronary cusp, to really pay no attention to the depth in relation to the non-coronary cusp. It will likely be an underestimation. We then pull the wire back, and we'll see Mohammed do this in just a moment, and we're going to release the valve slowly and methodically. We may lean on the delivery catheter to bring it to the outer curvature. Another benefit of the LAO view is that you're going to be able to see where the delivery catheter is on the outer curvature. So before I get to data and talking more about what we're doing with the cusp overlap technique, Nico, I wanted to get your insights on whether the technical modifications matter in reducing conduction disturbance rates.
Yeah, Hamal, look, we have to say that, these technical details that you've just presented, you've developed over the last several years. Of course, you've demonstrated not only in your center, but also in other centers around the world that, in fact, this technique does lead to lower permanent pacemaker rates. And so, we've transitioned not only in the implantation views, but also in the type of guide wire selection. So we typically use a Lunderquist now for all our double curve for all our transcatheter aortic valves. We start higher than we used to, and we like to bring the valve down. Now, one thing that we tend to look for, because there may be instances where your valve does not come down as much as you would like. And so you could end up with a relatively high implant. One thing that we look out for, especially on the non-coronary cusp, is we like to see the frame, the edge of the frame, straight on. If we see a little indentation of the frame, as if it's indenting, the edge of the frame is indenting inside the non-coronary cusp, it probably means that you're slightly a bit too high, and that you might have issues in later on in the procedure if you want to do a post-dilatation, because then you can maybe displace the valve a little bit higher. Each time you dilate that valve, the valve does foreshorten. It's a nitinol structure, so you got to keep that in mind. But one thing that I have to admit that I don't do routinely is go in the LAO view. I just stick in the ariocaudal view. I aim for that non-coronary cusp as high as I can. I go for the highest implantation possible for that anatomy. And given that the non-coronary cusp is the most inferior cusp in the body, when you look at a patient from an attitudinal description, then we basically don't have much control over the left coronary cusp depth. So if you nail the non-coronary cusp, you're sort of, married to the depth you get on the left coronary cusp, unless you're going to do some maneuvers in order to bring the valve more coaxial during deployment. But yeah, we follow that technique, about 99% of the way, Hamal, and it's led to some good results.
That's fantastic to hear. Yeah, I think that, the additional piece of information that I gleaned from that LAO view is really where the delivery catheter is along the aorta. And that helps me plan whether or not I'm holding steady on the delivery catheter or leaning forward. And I think that that's probably the most critical piece of information that I get from that particular view.
Okay.
Okay, so let's see the last part of the case.
Let's keep... Now we'll pull the wire a little bit before releasing this device. We'll start pacing again at 140, and Philip will start to release very slowly. And I'm controlling the catheter, as you can see, a little bit with a little bit of a push to centralize it. And we're doing it very, very softly. Pacing unbitter, yeah. And you see here that while I release, I like to go back to the LAO view, just to make sure I'm controlling my catheter. Just do it small and smooth. Okay.
Okay.
Yeah, so both are up now. I think we have stop pacing. I think we maintained a perfect height. What do you think, Philip?
Yeah. I think we come a bit up,
Maybe
slightly millimeter up.
Yeah.
But I think we're still in a very good position. As you can see, the hemodynamics probably, we have still with a wire in place, we still have a 60 diastole, and I think the valve is also good aligned.
Yeah. Okay, so we have good hemodynamics. Wir schreiben mal bitte.
Can we stop? So the final release was done in Echocardiography, and we have about 6 to 8 minutes left. So we'll try to keep the comments and the remainder sort of compact. But Mohammed, very quickly, you released an Echocardiography, and the second operator made a comment that the valve moved up maybe a little bit. I think for the audience, I think it brings back to what Hamal said. You cannot assess the depth on that Echocardiography view because it's always going to look much higher. And so, we have to bring back the point, especially for this webinar, that the depth of implant can only be appreciated in ariocaudal view.
Yes, I totally agree with you, Nico. I like to release an LAO because what Temal said, that not because I can assess depth in this view, but more or less it unfolds the catheter, so I can understand if my catheter is, you mentioned what do you call it? The main axis of the aortic valve. I like this terminology a lot. So I can see whether I need to pull a little bit on my catheter just to keep it central, which is something I can really appreciate in rheocaudal view, because in this view the aorta or the arch is not unfolded. So this is what I feel for the rheocaudal view. But I agree completely with you that to assess depth, we have to go to the cusp overlap view.
Okay, shall we go back to the video?
Keep in mind that, sorry, just 1 second. Just keep in mind that when you have the delivery catheter on those tabs, that the valve is not going to be square with the annular plane in most instances, because you still have something hanging onto the valve. It's not until you release the tabs when you go back into the cusp overlap view that typically you have parallax removed out of the heart valve platform.
So we had good hemodynamics, as you can see here. So we have almost no gradient. We'll do a pullback now. Kann ich? Okay. And now let's do a root shot, just to check the regurgitation on our final position. And then we'll also check alignment, because we can do this by looking at the C-tabs after implantation. Tigi? Gib mal bitte 15, 15. 15, 15, okay. So we'll now do a root shot. Angio bitte und Schuss. Okay. So we have a very, I think it's a very minor trace of AR, maybe at the left coronary side. What do you think, Philip?
I would definitely leave it like this. It's very, very mild. We have a high risk of embolization during post-dilatation. And of course, the core valve has such nice radial forces. Just leave it there for a couple of minutes, and probably the regurgitation is even less or gone. Yeah. So I think this is not anything that will affect the patient in the future.
So let's check it again and go to the cusp overlap view. Okay, so I'll do a picture here and I'll show you what I mean. So I think, at least fluoroscopically, we should have good commissural alignment here. This is, again, the cusp overlap or non-coronary side view. And you can see here that the C-tab is located on the right side of the monitor, which is exactly where the commissure between the right and the left coronary cusp should be in this view. So again, I do think that we could have a very nice commissural alignment in this case. If we go to the LAO view, you can also see here what has been shown in the study of Gilbert, Tang, that we have the C-tab located at the inner curve, which is also something that gives you a feeling that you probably have commissural alignment. You can, of course, check this afterwards using echo or using CT, but I think that we achieved here what we want concerning a very shallow implantation. Concerning the very short membranous septum, if you can look at the ECG now, probably she has a left bundle branch block, but she doesn't have any sort of AV block. And I think we have a good commissural alignment. So I think we're done now with the valve implantation. So let's remove the sentinel device now and then close the femoral artery.
Yeah, so Nico, again, probably, I mean, again, this technique is evolving, and probably, or I think this is true, if you want to assess your final depth, you should also probably do the angiogram, again, in the cusp overlap view, which is something we didn't do in this case. We felt that we were quite confident where the valve sits, and we were not concerned about AR. We went back to see the commissural alignment, but definitely if you want to assess your final implantation depth accurately, I think you should do this in the cusp overlap view as well.
Yeah, Mohammed, thank you. So Hemal, we have a few minutes left only. Should you try to wrap up the case and maybe some take-home messages?
Yeah, I think that, I mean, the thing about this case is that it followed all the principles that we talk about here. And so this is the acronym that Medtronic set up to basically give you a heuristic on how to think about this technique. Mohammed did each one of those things. And so we really look for this scorecard type of approach to check off each step to really get the perfect implantation with the outcomes that we think we're going to get with this technique. The outcomes have been shown uniformly now. And these are small studies. A lot of them are from my center and centers that I've proctored over the years. But we've got really great data now of single-digit pacemaker rates uniformly across the board utilizing this technique as we've discussed it. One of the major trials that is currently ongoing is the Optimized Pro post-market analysis. That basically has turned into the Cusp overlap trial. This is a multi-center 400-patient trial. We're about halfway done with the as-treated cohort. The interim analysis results are actually being presented at SCAI right now. And so actually Medtronic released a press release on those results, 171 patients. Currently, we have a pacemaker rate of 8.8% in the study. None of these patients had pacemakers coming in. We have rates of mild paravalvular leak of 19%, none were trace, about 80 to 81%, and no moderate or severe PVL. In addition to this, we've had no pop-outs, no valve embolizations, no use of any second valves. And so this appears to be a safe and effective technique, and I would definitely applaud Nico, you and Mohammed for implementing it so well in your practices, and Nico, obviously, for the foundational work that you did in understanding the relevant cardiac anatomy that has led to this technique prospering.